Hi everybody, this is Dr. Johann, consultant cardiologist at the Care Hospitals, Hyderabad. And today I've been talking about the diagnostic profile in cardiac amyloidosis. And we know that the whole journey for the diagnosis of cardiac amyloidosis has been a very long and tortuous one, right from the general practitioner to the super specialty or the cardiac specific center of excellence. And one of the reasons is because we've not had a protocolized based diagnostic workup. So the Indian specific guidelines for cardiac amyloidosis is based on an ECG where you have a poor RV progression V1 to V3 and the low voltage leads in the limb leads with normal voltage in the chest leads. Following that, an echocardiogram, especially the 4-chamber view where you see the thickness of the LV, especially the posterior wall, which is more than 15 millimeter, right ventricular hypertrophy more than 7 millimeter, and most importantly, when you're looking at that 4-chamber view, there's an atrial asystole or an atrial standstill, which gives you a very clear indication that you're looking at a hypertrophic disease, which is most probably amyloid. Then we also have the central corridor sign, wherein on the septum is a bright central portion with 2 dark areas in the interventricular septum. Once we move from there, the tissue Doppler velocities are extremely low, less than 10 meters per second, and the speckle trackling GLS, which is now a very important marker, is preserved at the apex, unlike most diseases where the apex is involved, where there's significant decrease in GLS at the basis. Now, when you have the ECG and echo, which is looking like a possible amyloid, the next logical step is to do a cardiac MR. And there are 3 things on the cardiac MR that we look at. One is the structure and function. Most of these people have a preserved LV function more than 50. We're looking at the T1 images and also the ECV, and we find that the myocardium of patients with amyloid have a very elevated T1, so elevated that it's possibly the only disease that we know of which has such elevated T1s, usually in the range of 1100 to 1300. And the ECV, which is post-GAD contrast, is again more than 40%, which is again very, very specific for amyloid. And in addition, you have the gadolinium, which is deposited in a subendocardial manner, just like ischemic heart disease. It's the only non-ischemic cardiomyopathy which has the deposition of amyloid in a subendocardial pattern, but here it is global. The story doesn't end here. Even if you have all these telltale signs and red flags of amyloid, you cannot treat these patients till the next step. And what is the next step? You need to do serum immunofixation and look for the light chain proteins in the serum and urine. Make sure that's negative, because AL amyloidosis has a very high mortality, and the mortality is happens in less than a year. So we need to rule that out with the immunofixation. Once that is negative, then we do the most specific test, which is the scintigraphy test using PYP scans, technetium PYP scans, which are now freely available. And after 1.5 hours, we look at the planar images and we look at the cardiac images. And here, if we find that the scintigraphy is 2 or 3, which means that there's more concentration on the heart rather than the contralateral lung, you have a diagnosis of cardiac amyloidosis, specifically TTR or ATTR amyloidosis. And this becomes a very important starting point for starting therapy, which we now have in India, thanks to Pfizer, that's tafamidis, which has a mortality as well as a hospitalization benefit of up to 30%. Thank you very much.